Thanks, Jessica. And thanks to all of you for taking time out of your busy schedule to spend a few hours with us this week. We have a lot of interesting and important content to share with you, but I think it all starts with the basics, taking a sexual history. For many of you, this will be a general review. But for those of you who are starting to take care of patients with sexual health concerns, this will serve to provide a guideline of approaches that you may find useful. So for myself, I have a busy focus on providing sexual health in a sexual health clinic at Columbia. I also see patients in a specialty clinic serving the formerly incarcerated, as well as a private practice for adolescents and young adults. Taking a nuanced sexual history is important in all these settings. As mentioned, I am the PI of the New York City STI HIV Prevention Training Center, and Jessica mentioned all the wonderful things we do for you all. So I have no disclosures, but again, as Jessica mentioned, some terms in this presentation may have been modified to align with executive order requirements that this CDC-funded grant has received. So I'd like to acknowledge members of our staff, Jessica, Gauri, Cindy, for helping to coordinate this intensive STI training course, and other faculty, Jason, Natalie, Jacob, and others, for their upcoming talks. So in our time together this morning, we're going to talk about the context for addressing sexual health issues, which will then provide the rationale as to why and how we should take a sexual history. I want to start off by reminding everyone that addressing prevention, screening, and treatment of STIs is extremely important. In 2024, there were at least 1.5 million cases of chlamydia, which represented a modest drop from 2019. There was also a decrease in cases of gonorrhea. However, there was a 42% increase in cases of syphilis and a staggering 82% increase in cases of congenital syphilis. So we have a lot of work to do. And while anyone can get STIs, some groups like young people, gay and bisexual men, pregnant patients, and people of color are at increased risk. But it's important to note that these disparities are unlikely to be fully explained by differences in sexual behavior and may instead reflect differential access to quality healthcare, as well as differences in sexual networks. For example, in communities with high prevalence of STIs, with each condomless sexual encounter, people face a greater chance of encountering an infected partner than those who are in lower prevalent settings, regardless of similar sexual behavior patterns. In addition to being prevalent, sexually transmitted infections are expensive, costing about $16 billion per year. And as dramatic as this may sound, the situation is actually worse and represents just the tip of the iceberg, as many STIs have no symptoms, as illustrated by the submerged base of the iceberg. So patients may not have acute action to seek care and may unwittingly spread infections to members of their sexual networks. We as clinicians also play a role in underdiagnosing STIs. If someone comes in with symptoms, we know what to do. We provide an assessment, we order the appropriate test, we make the diagnosis, we provide treatment and counseling. But if someone has no symptoms or is coming in with another health issues, we may not ask the right questions. And so appropriate screening, diagnosis, and treatment will not happen. So where do we start? There's an old saying that the journey of 1,000 miles begins with one step. And for our purposes today, that step starts with taking a sexual history. So why do we take a sexual history? Taking a sexual history may allow us to enhance service delivery to our clients, specifically through early detection and identification of sexual health issues, prevention of unintended pregnancies, reducing transmission and lowering community burden of diseases, enhancing comfort and pleasure during sex, as well as identifying and addressing other clinical and psychosocial issues. Now, the United States Preventive Task Force and the National Academy of Sciences recommend that providers take a sexual history from their patients at least annually. And 91% of patients agree with this recommendation. However, studies indicate that only 10 to 33% of providers obtain routine sexual histories, and when they do, infrequently ask about key parameters such as sexual practices. So therefore, we're missing opportunities for prevention, intervention, and lowering community levels of unintended pregnancies, STIs, and HIV. One of the important elements in taking a sexual history is to better understand any potential risks to their health that our patients may be taking. Getting this information paves the way to screening, counseling, and other interventions. What do we mean by risk? It could be condomless sex with a new partner, condomless sex with more than one partner, condomless sex with a sex partner who also has multiple partners. It could be condomless sex with a sex partner who has a sexually transmitted infection or HIV. It could be forced or coerced sex. And it could be also involvement with substance use, which may affect sexual decision-making and ability to protect oneself against STIs and unintended pregnancies. So finding out information can lead to action steps, such as STI screening, and we really want to focus and highlight the need for extra genital screening, as well as HIV screening, linkages to care, hepatitis A, B, C screening, and provision of vaccination, not only for hepatitis A and B, but also HPV, Mpox, and other infections. It could set the stage for having discussions about PEP and PrEP and DoxyPEP, as well as counseling, education about condoms and contraception, as well as behavioral counseling and referrals. Additionally, as you find out information through the sexual history, you may uncover additional issues that need to be addressed, which may not have been uncovered otherwise. And we'll illustrate that in our case vignettes a little later on. So let's talk about who we take a sexual history from. So with that scenario in mind, let me pose a scenario to you. Let's say you are in a primary care clinic or in an FQHC, and when we finish our talk this morning, these 5 patients are in the waiting room. Alicia is a 15-year-old female, goes to Catholic school. She's presenting for a school physical. Ricky is a 22-year-old male, formerly incarcerated, coming in for a pre-employment physical. Jason is a 28-year-old beautician coming in for evaluation of recent history of low-grade temps, sore throat, body aches and chills. He needs a note for work because he missed a couple of days last week. Vanessa is a 68-year-old retired librarian, half a pack a day smoker. She comes in because she has a nagging cough and is ready to quit. And Julio is a 60-year-old businessman coming in for a blood pressure check. So we're going to do a Zoom poll. And the question is, which of these patients would you take a sexual history from? None of them, or Alicia, or Ricky, or Jason, or Vanessa, or Julio, or all of them. So let's see what you all think. So we'll wait another minute to have everybody get an opportunity to click on their options. All right, Jess, what do we got?
85% said all of them.
Okay, 85% said all of them. Y'all are ahead of the curve. Fabulous. Okay, how do I get back to? Okay, so in thinking about who we should take a sexual history from, clearly adolescents and young adults are priority populations to engage. Over 48% of cases of chlamydia, gonorrhea, and syphilis occur among young people between the ages of 15 to 24. But we need to also think about what's going on with older adults. 40% of seniors between the ages of 65 to 80 are sexually active. 45% of people in the United States over the age of 65 are divorced, separated, or widowed, which means they may be seeking new partners. And they may be using dating apps to find these partners. Surveys suggest that, coupled with the increased availability of ED drugs, erectile dysfunction drugs, and the fact that the risk of pregnancy is off the table, and condom use being low in this population, about 6% as compared to 40% among college students, these factors contribute to data showing that chlamydia infections among seniors over the age of 65 have increased 50%, and gonorrhea infections have increased over 100%. So we touched on the why and the who. Let's talk about the where. In terms of where, there are options. It could be in the exam room by a provider, but nurses, community health workers, medical students, nursing students, public health students can also start the process and save the clinician time by getting key pieces of information before the patient has started to be seen. Additionally, to save time, we have also had the opportunity for patients to fill out self-administered surveys in the waiting room. Self-administered surveys potentially have several useful functions. They can standardize the risk assessment. They can normalize the process of asking sensitive questions. And some patients may feel more comfortable responding to queries on a piece of paper or a tablet rather than from a provider. And it may save time, allowing the provider to focus on specific areas of concern. But we need to make sure that the questions are written at an appropriate health literacy level and that there's no one looking over the patient's shoulder, which may compromise responses. And providers still need to review every response to make sure that patients understood the questions and we're not just providing socially desirable answers. If a parent, friend, or significant other accompanies the patient, another option could be having the survey administered in a triage area or room where vital signs are being taken. Speaking of vital signs, Michael Horberg from Kaiser Permanente was quoted as saying, "Sexual health should be the newest vital sign," an indication as to how critically important this information is and how regularly it should be collected in a normalized fashion. So when is a good time to take a sexual history? Clearly, it could be integrated into the HPI for any patient presenting with genital urinary complaints. But since many STIs have no symptoms, we should also consider taking one during any non-urgent acute care visit, during health maintenance visits, and also during follow-up visits for chronic disease management. So how do you go about taking a sexual history? These next few slides will set the stage and provide some broad recommendations. We will provide you a menu of words, phrases, and approaches, but you do you. Use what you feel comfortable with. The key thing is to ask and do so in a way that is considerate and respectful. And think about the end goal, to obtain information which may be used to help the patient. In doing so, you may uncover issues that may make you feel somewhat uncomfortable or may differ from your own beliefs or philosophies. However, getting on a soapbox and judging, lecturing, threatening, preaching, blaming, and shaming patients will not change their behaviors and may make it difficult for them to ever come back into your clinic or any clinic ever again. A case in point is one of our patients who related a previous conversation that she had with her provider. After she found the courage to ask about getting sexual health services, this was the response she received. You're only 15 and you've had 5 partners already? Don't you know that New York is the STD HIV capital of the world? How could you be so careless? What is wrong with you? And it's not just adolescents, but adult patients who are often criticized for the number of partners they have had or the type of practices they engage in. One study indicated that 25% of OBGYN providers expressed disapproval of the patient's sexual practices, leading patients to feel that they have been slut shamed. Another foundational principle in taking a sexual history is the need to assure patients of privacy and confidentiality. They need to be able to trust that we have their best interests in mind and what they tell us will be protected. Further, we all take shortcuts, but in taking a sexual history, we should not assume that based on a person's age, appearance, race, ethnicity, or whatever, that they are or are not having sex. And that if they are having sex, that it is in a exclusive relationship. And we should not impose a heteronormative point of view. In other words, that sex is only between a man and a woman. We have to be aware of and be prepared to provide services for a broad spectrum of individuals. While all patients require respectful and non-judgmental care, we have to be particularly careful with young people and our sexual minority patients. There's a concept called foregone care, which is care that someone wants and needs, but is not realized due to barriers. One of the major barriers to address is explicit and implicit bias by health providers and clinical staff. So this quote is noteworthy. A lot are not going to doctors because they're worried about how they're going to be treated. The perception is that primary care doctors are going to treat LGBT people differently, or patients are going to feel embarrassed. Further, in working with clients, we have to be mindful about our choice of words. For example, early and middle adolescents are concrete thinkers. If you ask a closed-ended question such as, "Are you sexually active?" you may get a response to them saying no. But no is not really no. They may be interpreting activity literally as movement. So if they just lie there, they're not really having sex. Or they may interpret activity as frequency and say no because they only have sex once in a while. Or they may interpret activity as having sex with multiple people and they will say no because they only have sex with one person. Or they may consider sex as vaginal sex and they may say no because they're only having oral sex. So language is important. Additionally, we often use the term partners when asking about sexual liaisons. That's a broad term and is meant to be inclusive, but it could be interpreted as individuals they are in a relationship with. So if the sexual encounter was casual, they may say that no, they have not had any partners in the past 3 months. So you may want to rephrase and ask, in the last 3 months, how many different people have you had sex with? And by sex, I mean any type of oral, vaginal, or anal contact. You want to use words and phrases that you feel comfortable with, but again, be concrete and specific. Many of the patients we deal with have low health literacy. So if you say, "Is the purulent discharge from your penis copious?" they may look at you like you have 2 heads. So instead, you may want to rephrase and say, "Tell me a little bit more about the fluid or pus coming out of your penis." Also, if patients use terms that you are not familiar with, ask them to explain, to break it down. So if someone says, "Yeah, man, I was smashing it raw," you feel me? The translation is, "I was having sex without a condom. Do you know what I mean?" Whenever possible, we recommend use open-ended questions which help patients to tell their stories. Relevant phrases include, "Tell me about," "Can you share with me?" "I'm curious about," "How?" For many people, being asked about their sexual history may represent a different experience than what they are used to in a clinical setting. So it's a good idea to give them a heads up, a signal about what is about to happen. Mr. Rodriguez, I know you're here to get your blood pressure checked and to get refills on your meds. But would you mind if we spend a few minutes talking about how things are going with your sex life? Many of my patients have questions or concerns that they would like to discuss, but don't know how to bring it up. This is a safe place for us to have these conversations. And providing the rationale is important about why we're about to ask these questions. We want to normalize. To provide the best care possible, I asked all my patients about sex. These questions may or may not be relevant to you, but I need to know so I can provide the best care possible to keep you healthy. So what are the questions we should ask? The CDC has outlined an approach called the 5 Ps, which stands for partners, practices, prevention of pregnancy, protection from STDs, and past history of STDs. So we're going to go through that one by one. So we want to ask about the number and sex of partners, current and past, starting with an open-ended question. So tell me about your partners. Tell me about the people you've had sex with. In the last 3 months, how many people have you had sex with? Are your partners people with penises, people with vaginas, or both? And how or where do you usually meet the people you have sex with? The question about where people meet their partners is interesting, particularly if they're using hookup apps. There's a correlation with having an increased numbers of partners and an increase in condomless sex. Continuing with probing about partners, we may ask, especially for teenagers, how old is your current partner? What was the age of the oldest person you've been with? So particularly useful for teens and young adults, if they have sex partners that are several years older than they are, they may find it difficult to negotiate use of condoms and or birth control methods with their older partner due to unequal power dynamics. We want to switch gears and talk about practices. Ask about the various types of sexual activity and timing of most recent sexual encounter. Again, an open-ended question. Tell me about the types of sex you've had with your partners. Or many of my patients tell me they have tried oral, vaginal, and anal sex. How about you yourself? And for men who have sex with men, are you a top, bottom, or verse? Are you engaged in insertive or receptive anal intercourse? And when was the last time you had sex, and was it protected? Again, unprotected or condomless sex within the last 72 hours may indicate the need for PEP and or Plan B. We should try not to make assumptions about practices and instead focus on what body parts are utilized during sex. So talk to me a little bit about which body parts you use when you're having sex with your partners. Prevention methods. Open-ended question. Tell me a little bit about your experiences with condom use, or help me to understand under what circumstances and with whom you choose to use or not use condoms. And if now is not the best time in your life to be involved with a pregnancy, can you share with me what you and your partners are doing to prevent a pregnancy? You want to also ask about past history of STDs. Tell me about any times in the past when you may have been tested for STIs. As far as you know, have you ever been tested? If so, where, when, and what were the results? If you had a positive result, were you treated? Did you go back for follow-up testing? Were your partners contacted and treated? Since then, tell me how things have changed in your life with respect to sex. So that was a basic overview of the core 5 Ps. But while helpful, we think it's important to expand our scope of investigation by adding queries about psychosocial issues as well as prevention of HIV and STIs. With respect to psychosocial issues, we're concerned about mental health issues, depression, anxiety, substance use, history of survival sex, sexual victimization, intimate partner violence, unwanted sex, and a history of incarceration. All of these may have implications in acquisition of STIs and may affect uptake and utilization of prevention modalities. An emerging area of concern relates to trauma in all its many forms. A particular area of focus are ACEs, which are a series of traumatic events that happen to a young person before the age of 18. These experiences fall into three buckets: abuse, neglect, and household dysfunction, and are rated on a scale of 0 to 10. Studies indicate a linear correlation between the number of ACEs someone has experienced and maladaptive coping mechanisms. Maladaptive coping mechanisms such as smoking, substance use, and sedentary lifestyles may contribute to development of chronic health conditions such as cardiovascular disease, diabetes, COPD, and cancer. Additionally, ACEs may impact sexual decision-making, which may contribute to enhanced risks for STIs and HIV. Screening for ACEs can be done via a short survey and may assist providers in better understanding why patients may engage in persistent risk-taking behavior and why adherence to health-promoting practices may be difficult. Adopting a trauma-informed approach, which essentially switches the paradigm from asking what's wrong with you to instead, what happened to you and how can we help? This essentially is going from a blaming and shaming approach to an empathic, trauma-informed approach, which can be extremely beneficial in working with clients. ACEs may contribute to and may be comorbid with mental health issues such as anxiety and depression. So sample scripts for asking about psychosocial issues may be, some of the patients that come to this office tell me they feel anxious or depressed at times. Tell me how things are going in your life. Have you ever felt the need to be in counseling? Have you ever been in counseling? Have you ever taken any medications? Have you ever been hospitalized for a mental health issue? Have you ever had a suicidal attempt? Do you feel the need to be in counseling now, or would you like to talk with someone? Additionally, clinicians may consider using the PHQ-9 or GAD-7 to identify depression and anxiety. Elevated levels may warrant referral to social work and psychiatric services. Substance use may affect a person's decision to have sex, who to have sex with, and may interfere with their motivation or ability to utilize protective measures. Substance use may also be used as self-medication. It may also help reduce hyperarousal and facilitate sleep. And there's significant interactions between ACEs, mental health issues, and substance use. So sample scripts may be, many of the patients I work with tell me they use alcohol or drugs for various reasons. How about you yourself? If you use alcohol or drugs, talk to me about what you use, how much you use, and under what circumstances. Have you ever had sex under the influence of alcohol or drugs? Do you feel or has anyone ever suggested to you that you need to slow down or cut back? In addition to the intersection of substance use and mental health issues, another component of substance use may be sexualized drug use or chemsex or party and play. This is drug use with the intention of intensifying sexual experiences. Some sexual minority males may use drugs such as crystal meth and or ketamine at sex parties. This dramatically increases libido, but it also may be associated with erectile dysfunction, which some individuals may counter by using Cialis or Viagra. This may result in a perfect storm wherein there is enhanced sexual arousal, improved erectile function, and the availability of multiple partners. You can really see the potential for enhanced transmission of STIs during this type of situation. Other psychosocial issues that our clients may be involved with relate to survival sex, sex as currency to obtain money, food, shelter, drugs, and so on. So a script could be, some of the patients I see in this clinic tell me that sometimes they have sex to get money, drugs, a hot meal, clothes, or a place to stay. Tell me what you think about this and if you've had any of those experiences now or in the past. Additionally, we also have to have a high index of concern about patients who may be involved in intimate partner violence situations. Have you ever had any altercations with partners in the past or currently? In general, when you and your partners disagree or have an argument, how are things settled? Do you ever put your hands on your partner, or does your partner ever put hands on you? And do you feel safe in your current relationship? Again, while IPV can occur in any relationship, we need to also pay close attention to the potential for it occurring within the LGBT population. A screening tool to consider using is the HITS survey, which stands for hurt, insult, threaten, and screen. And we'll talk about these psychosocial issues in more detail in our Thursday presentation. Incarceration. As you know, the United States incarcerates more people than any other country in the world. And there are significant racial and class disparities among those individuals who are incarcerated. Additionally, there's significant overlap between incarceration, social determinants of health, ACEs, mental health, and substance use. Not surprisingly, individuals with an incarceration history are at high risk for STIs. So in New York City, there was a study done where folks who were in our main jail, Rikers, were screened for STIs. And results indicated that individuals in incarceration settings had more STIs than all 10 of the New York City STD clinics combined. So while some jails and prisons have screening programs for STIs and HIV, most do not. And not surprisingly, people coming home for jail or prison may make up for lost time by engaging in condomless sex upon coming home. So a sample script to consider may be, some of the patients that come to this clinic tell me that they've been incarcerated at some point in their lives. Tell me about any experiences you've had with being locked up. Were you ever tested at any facility upon entry or release? If so, what did they find? And since coming home, talk to me about any types of sexual experiences you have had. You all are familiar with the status neutral approach to lowering HIV rates by treating individuals with HIV to make their viral loads undetectable and therefore virtually eliminating transmission to partners. And on the flip side, providing seronegative patients with PEP and PrEP to reduce acquisition of HIV. This is an extremely beneficial approach. In New York City, prior to COVID, rates of HIV had declined 35%, but COVID disrupted significantly the sexual health systems, and as a result, rates of HIV increased 14% after COVID. So we need to redouble our efforts to educate patients about HIV prevention. Sample scripts could be, in addition to screening you today for STIs and HIV, would it be okay if we spend some time discussing how to lower your chances for getting HIV? Have you heard about HIV prevention methods such as PEP and PrEP? Can I give you a little bit more information about them, and then we can see if they would be right for you? Additionally, for people with penises, introducing a discussion about doxypep might be useful to reduce acquisition of STIs as well. Have you heard about STI prevention strategies using doxypep? Can I give you a little bit more information about this, and then we could see if it would be right for you. While the CDC's method of taking sexual history is useful, a new approach has been developed by the New York City Department of Health and Mental Hygiene, which adopts a sex-positive assessment using the GOALS framework, which focuses less on risk-taking and more on assessing and providing services to enhance sexual health. So let's outline that approach briefly for your consideration. G stands for give a preamble that emphasizes sexual health. I'd like to talk with you for a couple minutes about your sexuality and sexual health. I talk to all my patients about sexual health because it's such an important part of overall health. Some of my patients have questions or concerns about their sexual health, I want to make sure I understand what your questions or concerns might be and provide whatever information or other help you may need. O stands for offer. Offer opt out HIV, STI testing and information. First of all, I'd like to test all my patients for HIV and other STIs. Do you have any concerns about that? Or help me to understand any concerns you may have. A stands for ask, asking open-ended questions. Tell me about your sex life. What would you say are your biggest sexual health questions or concerns? And how is your current sex life similar or different from what you think of as your ideal sex life? L stands for listen. Listen for relevant information and probe to fill in the blanks. Besides the people you've already told me that you've had sex with, tell me about any other sexual experiences. How do you protect yourself against HIV and STIs? How do you prevent pregnancy unless you're actively trying to have a child? And what would help you take even better care of your sexual health? Finally, S. S stands for suggest a course of action. So as I said before, I'd like to test you for STIs and HIV. I'd also like to give you information about PrEP, doxyPrep, contraception, and so on. I think it may help you enjoy your sexual life even better. But if time is tight, and it often is, you may want to at least ask a few basic questions and provide opt-out screening. So I know you're here today for a diabetes test or blood pressure check or whatever, but I want to make sure I'm not missing anything else that I can help you with. It's recommended that health providers ask all patients if they would like to get an HIV test. If you have ever had any sex without a condom, in addition to getting an HIV test, we should also add testing for sexually transmitted infections. Tell me what you think about that. So with those frameworks in mind, let's revisit the patients in your waiting room. As a reminder, Alicia is a 15-year-old female, goes to Catholic school. She comes in for a school physical. Mom has accompanied her to the visit. Again, one of the foundational principles in working with people in general and young people in particular is having a few minutes of privacy and assurance of confidentiality. Teenagers will very rarely provide accurate responses to sensitive questions in the presence of a parent. So how do you perform a parentectomy? How do you get a parent to leave the room? So sample script could be, Mrs. Johnson, thank you for bringing Alicia in today. In a few short years, she may be heading off to college, so we need to get her ready to become independent. That includes taking care of her health. In our office, we want to help young people and their parents with that transition. We make it a policy in our clinic for young people to spend time with the health provider alone. We will bring you back in a few minutes to review the results of the physical and to make plans for any next steps might be needed. What questions or concerns, if any, might you have? So again, after doing the traditional HPI, review of symptoms, and so on, we want to launch into the 5 Ps. So as it relates to Alicia, she says, yeah, she's had a 17-year-old male partner who's a friend of her cousin. They've been engaged in consensual oral sex. She denies anal or vaginal sex yet. In terms of pregnancy prevention, no condoms or contraceptive methods. It's not needed. Again, yet. Last period was 3 days ago. Protection from STIs has not been using condoms, and past history of STIs has never been asked, has never been screened previously. So based on this information, in addition to doing her school physical, you may want to consider screening for STIs, while also asking her if she has any questions about sex, and then providing basic information. You can reinforce that while some young people have had sex, others have decided to wait, and that is normal too. Also, you want to provide information that STIs can be transmitted by having unprotected oral sex, a fact that many young people, as well as adults, do not know. And even though she has not had vaginal sex yet, you may want to give her basic information about contraceptive methods. In the busy clinical setting, you may not have a lot of time, but I usually write a prescription to have clients view health information online at their convenience and in the privacy of their own homes and rooms. For contraception, I usually refer to bedsider.org, which provides information about contraceptive methods and narrative stories from consumers who have used these methods. We also want to take the opportunity to think about the HPV vaccine for her. As we know, the HPV vaccine is very effective against oncogenic strains of HPV. But parents are relatively uninformed and may have concerns regarding safety, efficacy, as well as concerns about promoting sexual activity. So we as providers can play an important role in giving accurate information and reframe provision of HPV vaccine as a cancer reduction modality. So you bring mom back in the room and you want to have a conversation with her in the presence of Alicia. Mrs. Johnson, thank you for bringing your daughter in today. Her exam is normal, and we're going to order some routine tests and fill out her paperwork for school. Additionally, I'd like to talk to you today about the HPV vaccine. HPV is a virus that causes cancer. Over 13,000 women are diagnosed with cervical cancer each year, and over 4,000 will die. To keep your daughter healthy and prevent her from becoming a statistic, I strongly recommend that you consider allowing us to provide the HPV vaccine. The vaccine is safe and works well to prevent cancer. I feel so strongly about it that my own kids have been vaccinated. Tell me about any issues or concerns you might have. So mother consented for Alicia to get the HPV vaccine. The next day, you received results that her oral screen for STIs was positive for chlamydia. She came back in for treatment and also to pick up her completed school forms and brought in her partner for screening and treatment as well. Let's talk about Ricky. Ricky's a 22-year-old male, formerly incarcerated, coming in for a pre-employment physical. In terms of partners, since his release a month ago, he's had 5 female and 2 male partners. He's been involved with a lot of coming home partners to celebrate his release. In terms of practices, he's been engaged in oral, vaginal, and insertive anal sex. In terms of prevention of pregnancy, he says, it's up to them to use something. In fact, I might even want a kid. In terms of protection from STDs, he says, nah, I only mess with clean people. I don't need condoms. And in terms of past history of STDs, he had negative screens upon entry into the jail facility. With respect to the expanded sexual health history, he reports using marijuana several times a day. In terms of his mental health screen, GAD-7 and PHQ-9 revealed moderate to severe anxiety and depression. His ACEs score was 5 on a scale of 0 to 10. Denies survival sex or abuse or intimate partner violence. So in light of the history, he was screened for HIV and STIs, as well as hepatitis A, B, C, and tuberculosis. He received education and counseling about the HPV vaccine, Mpox vaccine, PrEP, and DoxyPEP, and says, I'll let you know, I'm gonna think about it. As a result of his elevated scores for anxiety, depression, and trauma, as well as substance use, he was referred to social work for counseling. His lab results subsequently revealed that HIV, syphilis, hepatitis C, and quantiferin were negative. Antibodies to hepatitis A and B were negative. His urine nats was positive for gonorrhea. He returns to treatment, encouraged to contact partners and refer them to clinic for additional screening and treatment, started on PrEP, as well as being started on DoxyPEP. Eventually, he consents to getting the hepatitis A and B vaccine. So in the retrospective chart review study that we did in our clinic, 40% of men who have sex with men coming in for PrEP also lack immunity to hepatitis A. Additionally, Mpox was a huge issue in the recent past. Vaccinations have helped reduce the rate of new infections, but we're seeing a resurgence, most often among people who are not vaccinated. So we need to provide information and encourage vaccination among our patients who are at risk. So again, Ricky consents to getting Mpox and HPV vaccine at his next visit. Let's talk about Julio. Julio is a 60-year-old businessman coming in for a blood pressure check. He's married to a female, has 2 grown children, but he also has 2 male partners in the last 3 months that he meets via apps. He's had no sex with his wife for the past 5 years. She is a breast cancer survivor and reports having oral and anal sex with his male partners and describes himself as verse. His last sex was yesterday, unprotected. In terms of prevention of pregnancies, his wife is postmenopausal and they haven't had sex in quite a while. In terms of protection from STDs, he's been inconsistent with condoms because his partners tell him that they are on PrEP. And in terms of past history of STDs, he has not been checked since he was a teenager. His blood pressure is 160/110. He reports being inconsistent with his blood pressure meds, again, due to concerns about erectile dysfunction. So in terms of action steps, we want to evaluate his ED and his blood pressure meds. In addition to getting an HIV test, we want to do 3-site STI screening. Again, extragenital screening is extremely important. We want to get him on PEP and transition him to PrEP upon completion of his 28-day course. We also want to talk with him about DoxyPEP. He's also in line for several vaccines, shingles, pneumococcal vaccine, and he consented to get the Mpox vaccine at this visit. His labs show that HIV test was negative, urine NATs was negative for chlamydia and gonorrhea, but oral and rectal NATs were positive for chlamydia, and his RPR was positive for syphilis. He was treated for STIs and advised to notify his partners. He returned in a month. His repeat NAT screens were negative, and his RPR was lower. He transitioned from PEP to PrEP and was started on DoxyPEP and received his second Mpox vaccination. So let me use this case as a jumping off point for a moment. STIs, as we all know, are a problem for everyone, but particularly sexual minority males, we need to have a heightened degree of concern. Only about 36% of sexual minority males reported being screened for STIs at any anatomical site in the past year. And when evaluated, urethral screening was more common than pharyngeal or rectal screening. This was a large study done among 42 STD clinics. They saw 21,000 sexual minority males and screened them at 3 sites for GC and chlamydia. And not surprisingly found infections at all sites. But what's noteworthy is that 70% of extragenital gonorrhea and 85% of extragenital chlamydia were associated with negative urethral tests and would have been missed if extragenital testing was not done. So the take-home message is to consider expanding STI screening from just urine-based screening to also include extragenital screening as indicated. So let's talk about Vanessa. Vanessa is a 68-year-old retired librarian, half a pack per day smoker, has a nagging cough, and is ready to quit. Her cue to action, in addition to a cough, was that her husband died 2 years ago due to lung cancer. So in terms of the 5 Ps, she has a new sexual partner, a male, who she met online via a dating website. They've been engaged in oral and vaginal sex. Prevention of pregnancy is not applicable for her. In terms of condom use, they've been inconsistent with condoms. She says he'll lose his erection. And again, she has not been screened for STIs since she was a teenager. Action steps would be smoking cessation counseling, nicotine replacement therapy, perhaps getting a lung CT scan to screen for cancer, and based on information we found out, HIV, STI, hepatitis screening, and prevention using appropriate vaccines. So her results show that she is negative to hepatitis C, she has antibodies to hepatitis A and B, her syphilis test was negative, her oral and urine NATs were negative for chlamydia and gonorrhea, but her HIV test was positive. So STIs, HIV do not discriminate. Anyone can be at risk if they are having condomless sex. So our last case is Jason, who's a 28-year-old beautician coming in to get a note for work. He missed 2 days last week due to low-grade temp, sore throats, body aches, and chills, but feels better now. So we're going to hold on Jason's case, and as a teaser, we're going to discuss him in more detail on Thursday in our presentation on mental health and STI. So hopefully you all will rejoin me for that presentation. So take-home messages. Sexual health taking is a part of regular history taking. We want to ask early and often, particularly for young people. They may say they're not having sex in January, but when we see them again in May or June, the scenario may have changed. We've outlined several different approaches. You want to use an approach that you feel comfortable with. Change the language, whatever you want to do, but integrate it into what you commonly are doing now. Information obtained from a sexual history can drive clinical evaluation, prevention, and management strategies, not only for STIs, but for other aspects of sexual health, contraception, as well as prevention issues, vaccine, as well as other clinical issues, hypertension, smoking cessation, etc. Additionally, it could open the door for assessment and linkages to care for mental health support. And we'll talk about that more on Thursday. So I'm going to stop here and see if there's any questions or any issues in need of clarification. Thank you.
Thank you so much, Dr. Cohall, for that presentation. It's very comprehensive. All right. So one question we have here is just about the length that this can take. What would you say to providers who are concerned about balancing the amount of time they have for appointment with the amount of information that you're talking here about wanting to gather?
Yeah, I mean, again, as providers, we're asked to do more and more with less. So again, thinking about how you can manage your workflow and your work environment is critically important. Using the self-administered surveys could be important. Having other people on your clinical team work at the top of their license by doing a sexual history and providing you with that information is important. But even if those opportunities aren't available to you, you may want to just ask a few basic questions into your HPI review systems, etc. And hopefully, if you're in a primary care setting, you're going to be seeing patients on a continuity of care basis. So you may start the conversation at one visit and continue it at a subsequent visit. But again, not asking, not bringing it up leaves us to miss opportunities that can be problematic, not only for the patient, but the community as well.
Great, thank you. On a similar vein, a person asking, could I just offer STI testing without asking all of these questions?
Yeah. Yeah, so that's again, opt-out screening for STIs and HIV. And again, many patients are coming in anyway and getting urine tests and blood tests. And I think, yeah, you can just click off the additional tests, but let them know that, hey, in addition to screening, doing your lipid panel and your hemoglobin A1C, I also want to screen you for STIs and HIV. And, we'll talk about it in more detail when we get the results. So absolutely integrate it into your workflow.
Thank you. And as a clinical provider, do you have thoughts on using a provider-administered risk assessment versus something electronic like an iPad? Do you feel that an electronic questionnaire allows for good risk assessment?
Yeah, I mean, in our clinic, patients, while they're waiting in the waiting room, use an iPad to fill out surveys that address social determinants of health, address anxiety and depression, and then that gets reviewed by our staff. And again, studies really indicate that patients really feel comfortable in doing self-administered surveys. Again, the caveat is you just have to be careful because sometimes the surveys may be written at a very high literacy level, or patients may be in a rush, or they may be, just answering all the questions as yes or no, giving socially desirable responses. So they still need to be reviewed, but we found it very helpful and useful in picking up on things that we may have missed. Because again, as we said before, we all cut corners. We think we know what's going on for patient, but particularly for adolescents and young adults, they're great actors. They may look and talk as if everything is fine, but when we start probing, when we start asking the right questions, we identify that there's a lot of issues going on that need and require our attention.
Thank you. If patients have a history of vaccination for Hep A and B, would you still do testing for those?
Yeah, I mean, we're finding that even people in this country who have had vaccination as children, when we screen them, if they're interested in PrEP, we're finding out that in some cases the immunity may have waned. So yeah, we screen everybody who's coming in for PrEP for hepatitis A, B, and C, and then vaccinate for those folks who are not immune competent.
Got it. Thank you. And then a couple of questions related to caring for adolescents. Can you speak a little bit more on your recommendations for separating a parent from an adolescent when you want to talk about sexual health topics? Just we've got folks pointing out just how that can be difficult and a little uncomfortable.
Yeah. So yeah, that's a great point, and it's really fundamental, not only in trying to identify sexual health issues, but also mental health issues, um, issues with school, whatever it is that is going on in that young person's life. Ideally, that young person and the family should have had the policy explained to them pre-adolescence. So if someone's coming in at 8 or 9 or 10 years old, we want to set the stage with the parent by saying, hey, listen, pretty soon when your son or daughter becomes a teenager, we're going to need to change gears a little bit. We want to recognize that they are becoming more independent. We want to help foster that independence. So I'm going to need a few minutes at every visit to start having conversations with them. So if that's been done, parents are forewarned and prepared about what will happen. But if you're just starting off with a new patient and they're 14, 15, 16, or whatever, and they have not had that conversation previously, um, you have to introduce it to the parents and introduce it in a way that's comfortable and respectful. Sometimes what we do is we will take the parent out of the room, walk them down the hall or into another room, and ask them if they have any questions or concerns that they didn't feel comfortable bringing about in the presence of their child. And we may find out that the parent or people in the family are dealing with significant health issues, that there may be a lot of strife in the family, impending divorce or whatever. And parents then really appreciate that opportunity to discuss their concerns without their son or daughter being present. And then we say, hey, just like we've had an opportunity for you to talk with us individually, we want to do the same thing with your child. There's been studies that have been done that really look at this issue, and they find that for the most part, parents welcome the opportunity for providers to have sensitive conversations with their son or daughter, not only about sex, but about substance use and about other issues. So we feel somewhat uncomfortable and reluctant, but in many cases, that fear or those concerns are not well founded. So again, I would encourage you to figure out a script that you feel comfortable with, try it out. And again, it should be routine. This is normal. This is what we do in this clinic. Um, in certain circumstances, if there's an issue with the parent um, not leaving and you think that there's a need for the young person to get services, that young person may need to be referred to another clinic in your community where they can receive confidential services, whether it's a Planned Parenthood or a DOA sexual health clinic or another type of health provider.
Great. Thank you so much. One other question specific to adolescents around explanation of benefits. So, do you have suggestions on how to get around that to still have confidentiality for a young person, knowing that EOBs tend to be sent to the home?
Yeah. So yeah, that's a critical issue. We can practice and provide confidentiality in interpersonal interactions with young people and parents, but that can blow up with respect to the EOB. So again, in a clinic setting where patients have Medicaid, that's usually not an issue, but in private practice, it could be. So again, that's something that you need to alert the young person to and help them problem solve what they would like to do if there's a need for STI testing. In some cases, that could be an opportunity for you to act as a mediator between the young person and their parents to explain why these tests were being done, and what the need is. In other cases, it could be that the young person on the no way, shape, or how want the parents to be involved with sexual health issues. That's a patient that may need to be referred to another setting. Or it could be, that the patient is working or has an allowance and can pay for the test themselves. So you can arrange for the bill to be sent to your office, and then the patient can pay for it utilizing their own resources. So there's a few ways of getting around it, but it needs to be discussed with that young person before the tests are done. Thank you very much, and I will see you on Thursday. We have an exciting agenda for today and the next couple days, and we appreciate you all tuning in. Thank you.
Great. Thank you so much, Dr. Cohall. That was a fantastic presentation.